Enjoy your meeting.
Okay, your screen is up, Carla.
Great, thank you.
Just a reminder, today's meeting is being recorded.
So again, thanks for everyone attending, and thanks for the opportunity to speak a bit about lung screening. The real focus for the webinar is to kind of review and help, again, assessing how to build and how to optimize a currently existing lung screening program, or if you don't have a current program, some things that we have implemented over the last 4 years with the inception of our screening program in January of 2012, and bring forth some data and then some practical points and some resource materials for all those who are attending the webinar with some important links for a toolkit. And so with that, I'll go ahead and get started. I want to first thank kind of a core group of the Rescue Lung, Rescue Life team, and a lot of these slides are really the shared work of this group. Dr. Brady McKee from our radiology department, who developed the initial Lung-RADS, which is the validated measure of standardization for radiographic reporting for lung screening. Dr. Andrew McKee, Director of Radiation Oncology, who's been kind of the leader of this team and moving things forward, and Dr. Sean Regis, who's kind of the gatekeeper of our database, and Dr. Andrea Barandi-Kitts, who's not only a patient advocate, but done a lot of ongoing great work with smoking cessation and a lot of moving our research work forward in our group. So I think we're all certainly familiar with this piece of data that's been kind of a cornerstone and a game changer in lung cancer screening, showing a 20% reduction in mortality. And as the data moves on with this database, looking at the patients who may greatest benefit from lung screening, and this is kind of a evolving process.
I want to apologize, everybody. Right now we're having a little bit of this. Okay, your screens are up. Great. Sorry, go on.
Okay. So with that, I want to kind of let you look at a timeline, again, kind of the reference point from the NLST, but also the NCCN, the evolution of who actually should be screened. And I think going forward, there will be ongoing changes to the patients who will be screened, who will benefit the most, so that we're screening the appropriate population. But this really just highlights kind of the evolution of a program outside of the NLST, which is our program, and looking at the evolution between before lung screening was actually covered by third-party payers to the evolution of where now with shared decision-making, we're getting coverage for these type of screening exams and testing. Just as a benchmark, we've screened over 3,800 patients, and many of which are in their second and third phases of screening. And we've identified, as of July of 2016, we've identified 100 lung cancers out of that population, with 84% of those being early stage. Just as a reminder, you know, Group 1 is kind of the classic NLST criteria for the high-risk group patient based on their age, when they quit smoking, and their PACUR history. Something that currently is not covered by third-party payers is what we identified through the NCCN as Group 2, and the specific differences between Group 1 and Group 2 are that they're a younger population. The starting point is at 50 years of age. Their PACUR history is less, but they may have a specific additional risk factor, not including secondhand smoke, and I'll break out those specific differences that may include environmental exposures, an immediate relative with a history of lung cancer. So recognizing that there are patients who, while they may not meet the criteria of the NLST, certainly are considered higher risk. And what some of the data I'll present to you today going forward may certainly prove that the incidence of cancer that we found in our patient population is in parallel to the incidence of lung cancer in the screen group of Group 1. So this is kind of drilling down a little bit about the Group 2 risk factors. Again, I mentioned personal cancer history, prior cancer, family history of lung cancer and a first-degree relative, chronic lung disease, all of which are kind of cited there, and possible risk factors for carcinogen exposures from the environment. And radon, although it's very hard to assess, that's a category there, it's hard for folks to know exactly how much their radon exposure is, but we know it's an independent risk factor for lung cancer. And again, it does exclude secondhand smoke exposure. So just some data from our patient population to give folks a little bit of a sense of group 2. I mean, over time, if the data continues to bear this out, we would foresee that this would be a patient population that would be offered and covered by third-party payers, we would hope, because of their risk and what we've identified already in terms of their incidence of cancer. And it's just important to highlight these different entities of specific risk factors. Again, the personal history of smoking related to cancer, first-degree relative, those who have chronic lung diseases, and exposure history from the environment. This is just to kind of remind us, it was in 2013 that the USPSTF came out with their recommendation. You'll note that the age range is different here. It's actually age 55 to 80. Currently, third-party payers are only covering age 55 to 77. Again, these are things that I think will be dynamic as we move forward in terms of who will ultimately be covered for screening. But they specifically identify the 30-pack year history, the patients who have quit smoking within the last 15 years. And the other important point that they added to the USPSTF is that it's up to the clinician to judge when they're offering in shared decision-making a patient to be screened, is that patient does they have a cardiopulmonary status that would allow for a curative intention with surgery? Would they be able to undergo such a procedure? The one thing that I will highlight from our program is we did not exclude patients who were considered non-surgical for either cardiac or pulmonary reasons, because we had agreed by consensus that SBRT was a viable option for therapy in those patients who otherwise could not be considered surgical candidates. So our patient inclusion does include patients who may not otherwise have been considered for a definitive surgical intervention. So I think some things that are very practical points that we have to highlight. Again, the benefit now here is that initially in lung screening, up until just in the last year, third-party payers were not covering this at all, the cost of a CT scan. So I think there's going to be a huge shift in the volume of patients coming through, because by best estimate, about 9 million people in the U.S. would qualify under the current inclusion criteria to be screened, just to keep that perspective. It's really important to engage and have kind of front and center the primary care physician, because they really are considered the gatekeepers of screening. And by engaging them in your program early with educational tools and equipping them with resources, the thing that we've identified is that for the average primary care who has, say, 2,500 patients in their patient profile, probably less than 75 of those patients, out of that 2,500 bank of patients, will actually meet the criteria for screening, and of that, only maybe 4 or so would have a positive Lung-RADS finding that would suggest escalation of care. So that's an important point when talking to primary care doctors, because the perception initially would be that they might be overwhelmed with the findings on the CT scan and the increased workload and burden of managing that. But we've identified that while the primary care should be front and center, it doesn't overwhelm the workload when you look carefully at the screening criteria and how that bears out. You can see under the primary care heading there that there's information now, shared decision making. This is another important point. In order for CMS to approve and cover third-party payment for the lung screening CT scan, there needs to be a defined shared decision-making clinical visit, whether it be provided by a physician or a advanced practitioner, a non-physician advanced practitioner can provide that same information. and that needs to be documented. And I'll go over in a little bit more detail what the requirements of that are. And then answering questions for the patient, radiation exposure, the anxiety that may be brought about by screening, helping the patient have a perspective by which to know do they want to go forward with screening if they meet the basic inclusion criteria. And I'm also going to highlight at the end, we used a risk calculator that's, we'll share a link with that, called the Pulmonology risk model. And the benefit of that is it's a very well-constructed, validated model that a patient or a clinician can utilize, plugging in very available patient information to stratify if they, number one, if they're eligible for screening, number two, a perspective of breakdown of what their anticipated incidence of cancer could be if they move forward with screening. We'll talk a little bit about false positives. The shift to reduce false positives that is unique and different compared to what the NLST guidelines were. They had a lower size threshold for the pulmonary nodule to be positive, and therefore their rate of false positives would be expectedly higher. But with Lung-RADS and the evolution of the reporting system and the American College of Radiology's shift of changing the threshold to 8 millimeters, the reduction of false positives is significantly reduced in that context. Now, talking a little bit more about operational things, the important part is not only to recognize appropriately and screen the right patients, but once that you get a patient into a screening program or engage that patient and their primary care physician or other ordering provider, how to manage the patient to make sure they don't get lost to follow-up, that they're coming in for their studies appropriately, if they're continuing the program, and then how to manage abnormal results. Those are obviously important points that we'll highlight in a moment. And this is just kind of a nice step chart, kind of talking about what are the moving parts in a program, and I'm going to highlight these. You really have to have physicians from specific departments, most importantly in the primary care arena, but also having a multidisciplinary steering committee, which we personally will meet on a monthly basis depending on the needs. In the early startup program, we met much more frequently. And we also had, we have a weekly multidisciplinary conference where the positive Lung-RADS cases are discussed in detail by a multidisciplinary group that really embodies radiology, pulmonology, interventional pulmonology, thoracic surgery, and interventional radiology. There's also a whole host of medical and radiation oncologists present in pathology where it's appropriate. But these are things that I think really also help to, by consensus, narrow the need for unnecessary escalation of care. The database, and again, this is part of, CMS criteria, is that you must keep a registry and a database of all the patients that you are tracking and maintaining in your screening program, and that should be kept up to date and current. And it's also kind of a safety net for your program to have accountability to that. But there are very specific requirements by CMS in a lung screening center that have to be maintained in order to garner reimbursement for the studies. I mentioned Lung-RADS. While there are other standardized reporting systems, we use the Lung-RADS. It's validated. It's been touted and refined by the American College of Radiology, and you can go on their website and see updates kind of in a dynamic fashion. The top of the tree here is really the program navigator, and you really need to have an independent staff member or members, 1 to 2, to help not only navigate the data and maintain the database, but also to navigate the patients appropriately so that you know that phone calls are being made, follow-ups are being kept when patients cancel a screening exam so that those patients are not left in a gap of care. This is really a more detailed slide that talks about what our steering committee looks like. And so I'm going to just briefly highlight. You can see here there's multiple areas within the infrastructure of the institution, not only on the clinical side, but also on the administrative side that are kind of key to make the program work and continue. Radiology, primary care, pulmonary medicine, oncology, thoracic surgery, laboratory medicine, specifically with pathology, senior administration, radiology for workflow, all the different work staff to make sure that you're able to manage the capacity of the increased number of CT scans that would be performed in a given department, so that workflow meshes nicely with the day-to-day routine of other studies that are being done in that department, and also to account for proper staffing so that things work out well in that way. We talked about the oncologic services, marketing, getting the word out to patients and to physicians, education and CME for physicians so that they have a level of comfort with this evolution of screening and understand the most recent guidelines. Business development, always you have to have a business plan, and our toolkit offers that to you. So if those of you who are wanting to refine your program or are looking to start up the program, then our toolkit will provide you with some go-bys that I think you'll find helpful. And then philanthropy, a lot of times there are patient advocates, grateful patients, or folks who are really strong participants in philanthropy who can help drive a program and be a source, a resource for things that cost that are outside the reach of the institution itself. So with that, I'm also going to kind of hone in. I mentioned a bit about the program navigator. We also added here, research subcommittee, and what we found is that we have about 62% of the patients who participate in lung screening are enrolled in one or more research studies. And I'll talk about that toward the very end, about some potential things that we've identified over the last 4 years that really could have significant impact on clinical care, preventive medicine in patients who are getting screened for lung cancer. This is probably one of the most important slides. It's basically, from start to finish, how do patients potentially flow through the system in a very decentralized model? And there are a lot of parallels to how we screen lung cancer, manage the results, standardized reporting system that really are a lot like what you may be familiar with BioRADS for mammography. But I'll put in here, and I'm going to add, although it's not marked on this slide, SDM is the shared decision-making encounter. And that really can begin with the patient either seeing or hearing about lung screening, wanting to inquire if they're eligible, and by trained staff, going through the questionnaire that I've already shown you is a great way of beginning that conversation of shared decision-making, providing patients with written and verbal material of frequently asked questions so that before they make the jump to actually get screened, they've been informed. There's truly a prep for informed decision-making. The other thing I would add where you see PCP order, prior to PCP order, the expectation by CMS is that there will be, again, either a physician or non-physician provider who is trained in lung screening who can have an informed clinical visit to go over these things that I've mentioned, so that when patients say yes to screening, they're clearly going into it making an informed choice about it. Now, if we look here as the intake staff, again, these are intake staff that have been trained. They've been given a verbal, kind of a written script, and they're given information to guide the patient. Off the bat, you can often identify if a patient is going to be a qualifier just based on their age. It's very simple. The criteria is quite simple. If they don't qualify, they're referred back to their primary care doctor for further instruction because there's multiple teachable moments here. We've identified about 11 places in this decentralized model where there can be many offerings for smoking cessation, assessment if a patient's a smoker, have they ever been screened for COPD. There's lots of PREV health and health maintenance opportunities all along this pathway to be afforded not only by the physicians but also by trained staff, from the folks who answer the phone calls to the folks who are doing the CAT scans and who are working with the patients in the waiting area for their scan. So The other thing, if they may qualify, but it's not clear fully by the questionnaire, more information that needs to be gleaned, especially for us because we screen Group 2, there would be a callback and a more detailed history with that Part 2, Group 2 questionnaire. If they did qualify, then they go back to to the primary care shared decision making. If they're not a Lahey patient, they would actually go to their outside primary care, and that information could still be shared outside. If the patient wanted to participate or the physician would place the order, then that would move forward and the scan would be scheduled. Another important piece here is that we, in our first year of screening, it happened to be the worst, one of the biggest years of flu epidemic. And so you can imagine a very young screening program now with kind of an epidemic of flu. You know, one of the key criteria for screening is the patient must be asymptomatic. So we actually looked at that data, and because we had a screening questionnaire, meaning that you had your visit, the decision was made to move forward with the CAT scan. Step 2 was 48 hours before they had their scheduled CAT scan, the patient would be called, and they would go through a checklist questionnaire to make sure they weren't febrile, they didn't have a new cough, and that they truly remained asymptomatic. And that markedly reduced patients inadvertently getting screened and helped also reduce the potential for false positives because of that 48-hour pre-screening, just to make sure if they did have any of those symptoms, their primary care physician, the patient was either instructed to call their primary care doctor, or their CT scan was actually pushed back at least 4 to 6 weeks to allow ample time for the symptom to resolve. And then again, they were screened again with a questionnaire to make sure that they were asymptomatic. The other things that I would highlight here is the benefits to the patient is that these screens don't require an IV. They don't require the patient to change into a gown. They take less than 10 seconds. So they're very easy scans for workflow to incorporate in your program. Now, if a patient, when we refer to S negative and S positive, this refers to any incidental finding that's either not related to lung cancer, lung nodule. It could be anything from a thyroid abnormality to a kidney or liver abnormality to a vascular anomaly. Just any of those things that are would not be considered under the purview of a potential lung cancer or lung nodule. If they have an S positive, we have defined guidelines of information given to both patient and to physician to allow for appropriate next step, or if consultation is needed by another subspecialist, that can be rendered or defined by the primary care physician. This again just kind of iterates in a more simplistic way this decentralized model. Education of patient and physician. They get a 4-page FAQ that can also be given to the providers as well. Physicians get specific literature with the evolution of changes so that everyone's up to date and screen their patients for the right reason. And the safety net here is even if a physician inadvertently ordered a lung screening CT scan, a questionnaire is still reviewed prior to scheduling the CAT scan with our navigating team, so that if a patient was sent for screening but found to be ineligible, we capture that so that they're not inadvertently screening incorrectly. So kind of focusing now a little bit, changing gears to focus a little bit about Lung-RADS so that we have kind of a baseline to work with. Again, it's a standardized reporting system radiographically. It helps risk stratify and guides in the report the ordering physician to next steps, which the majority of patients, it will be only that they have a negative CT and they would need annual screening. So it becomes very simplistic. If they have a Lung-RADS 4, which I'll go into more detail what those definitions are, that is considered highest risk based on radiographic findings, does require escalation of care, which is a very small percentage of all patients who are being screened. So the majority are going to fall into Lung-RADS 1 and 2. But with this, you have a way of having a uniform way, a consistency between the radiologists and how they're interpreting the scans and communicating to what's being given to the ordering physician, so that there's not this lack of uniformity and variability in what's done with the patient. So you're hopefully reducing unnecessary testing or unnecessary escalation of care in the patient who's got not a significantly abnormal CT scan. So Lung-RADS, just in a very simplistic way of thinking about it, there are categories, and again, the ACR is the great reference point to find that information as it changes, but in a sense, Category 1 is a negative scan recommendation for a 1-year repeat CT scan. Category 2, benign appearing based on multiple radiographic criteria or stability, and a 12-month CT scan is recommended. Category 3, there may be a positive finding, but positive is defined as anything from a ground glass opacity to an airspace process to a nodule less than the 8-millimeter threshold. Therefore, shorter interval of radiographic follow-up would be recommended, but it'd still be leniency for clinical judgment as to whether a patient needs to be seen, because they could have a whole host of diagnoses from pneumonia to sarcoid, a variety of other things that might require additional evaluation, but but more times than not, it can be simply followed, again, if an asymptomatic patient, with a shorter interval CT scan. And again, Category 4 is the most suspicious of all findings and requires some level of escalation of care, which may not necessarily lead to a biopsy, but may lead to at least evaluation and further risk stratification. Just to highlight more specifically Category 4, again, a solid nodule greater than 8 millimeters, a new solid nodule greater than 6 millimeters with an interval change in the nodule or a pattern of growth greater than 2 millimeters or more. If the ground glass component has now evolved into something more solid, more than 50% solid. And again, these are things that are hard to commit to memory. This is where you can have a reference, again, to ACR for the Lung-RADS criteria in much more detail. And this is a very busy slide, I know, but this is kind of a nice breakdown of the categories of Lung-RADS. And as I mentioned, I would always have you refer back to the ACR because it's dynamic and being kept up to date. And it kind of gives you a nice perspective of the probability of malignancy relative to the finding. Here is just a quick algorithm about nodule follow-up, again, taking the high-risk patient. Of all the patients who qualify for lung screening, there's only going to be approximately 1 to 2% of patients who actually have a significant finding, i.e. being that of lung cancer. I put in a bit of a plug here. There's often a lot of questions about, well, how do we adopt Lung-RADS and how do we integrate that and how do we have a conversation with our radiologist? And there's some simple ways, and again, the societal guidelines for them is, again, the ACR. But this actually can be the phone app that can be downloaded. It also can be downloaded to your computer. But it basically is a radiographic-driven Lung-RADS app to train the radiologist into adopting and becoming certified, I shouldn't use the word certified, but at least become more competent and more uniform in interpreting these scans. And it's based on a large clinical database of a library of films that have all the different categories of Lung-RADS. And this will become important when you look to be a lung screening center because there is a requirement by CMS to have your radiologist trained in this way. So it's not everyone can read uniformly a Lung-RADS scan. It does take some degree of training over time. And this is actually, I put the website that it can be referenced, and this is something our radiologist at Lahey kind of came up with and created. But the feedback has been it's a useful tool for those who are looking to buff up their skills. And it can be used by anyone, but just something for you all to have and see. This is just a quick perspective on, we talk about, we actually were one of the groups that went to CMS back before they made the movement to offer coverage for lung screening. And there was much debate about the cost for screening, and there was much debate about data And we have to say, there's really, if you look at all the things that we currently screen for as part of preventive health and health maintenance, there is no other cancer or screening for cancer that's been as well studied as lung cancer screening. I mean, it just doesn't exist. And NLST did a tremendous service for looking at this in such a scientific way. I think the work going forward is to further cone out patients and then determining, are we screening the right patients? Do we need to shorten the span? Do we need to more specifically hone in on the span of patients who should be screened? If you get this perspective here, the cost per life year saved would be approximately $19,000. And if you look at it compared to cervical, colorectal, and breast, tremendous amount of cost effectiveness in the long run, because that doesn't even take into account, as I'll mention, with lung cancer screening, you often will capture patients who they're smokers, right? So you actually capture patients who maybe have never had a formal pulmonary function study, who've never had counseling and direction for smoking cessation to change behavior. I mean, all the things we think about patients who smoke get hospitalized for, detecting early coronary disease by coronary calcifications that are found incidentally on CT scan. There's just a whole host of things going forward that we think will bear out, that there'll be other cost savings for quality of life for patients and for reduction of hospitalizations potentially by using these opportunities of screening to capture more than one educational or teachable moment. So let's kind of drill down for a moment in the CMS. You know, in order to have your patient screened, in order for it to be paid for by a third-party payer, you have to have kind of the following criteria met. You have to meet the guidelines here, age 55 to 77. They have to have no symptoms. Tobacco smoking for at least 30-pack year history. Again, we're talking specifically, they're covering Group 1 right now. Hopefully Group 2 will soon follow, but that's not there yet. They have to be either a current smoker or have quit within the last 15 years. And then a formal written order has to be made, also showing a documentation in the order that there was a reference to shared decision-making. Now, other things that are going to be important to that is that not only is there shared decision-making about the pros and cons of screening to the patient, they meet criteria, but also that they have been counseled in smoking cessation, been provided tools for that, and then that you're also submitting to a national registry to maintain a standardized database for all patients in your institution who are being screened. Now, this is very important because patients are not going to be happy if you try to screen them and they get a bill for their lung screening scan when it otherwise should have been covered if we had met all the criteria. So let's just take a moment because I think this is probably one of the most practical points in this slide set. Again, shared decision-making by a physician or non-physician practitioner who's trained, use of one or more decision aids, discussing in detail benefits and harms. And that's why I think choosing a validated risk calculator is more practical. And I'm going to keep referring to the Tamagotchi risk model because I think it's simplistic and it gives a nice perspective and helps the patients understand it. It's very user-friendly for both the physician and the patient. You have to have a plan in place and document for your follow-up of your diagnostic testing, including the incidental findings. That you have a plan in place, and I would really highlight the utilization of your multidisciplinary committee so that there's a consensus pathway in what's being recommended or being done. And by using Lung-RADS, the intention of Lung-RADS is to minimize unnecessary escalation of care based on the data. And that you've actually given patients by maybe an FAQ sheet, a lot of questions that come up for patients is how much radiation is this? And we can be very reassuring in that as the evolution of the technology goes further, the minimal amount of radiation is at the very least it's no more than a mammogram. And that amount of radiation is getting smaller and smaller as the protocol for refining the CT scan, so it's not dipping into the renal territory. It's really keeping a more cone view of the thorax. And that's been an evolution since over the last 4 years also to minimize incidental findings. Counseling it's kind of self-explanatory here. I'm going to drill down a little bit more on smoking cessation and give you some tools that are practical, but you definitely need to have documentation and have some meaningful, either online or by telephone or written materials or a smoking cessation class or team embedded into your screening program. Radiology imaging facilities. So there is a requirement. This came out, recommendation not only from, this came back from the ACR and also went on to CMS, that to be a center, your radiology team must meet the following. And I won't go into a lot of details in the interest of time, but you can see here, standardized reporting system, teachable moments, even through the radiology department, and the registry is important. And the type of scans you're doing, the technique you're doing have to be uniform. I also will highlight here, what does your radiologist need to be able to meet the lung screening criteria by CMS, board certification, documented training. But item 3, involvement in the supervision and interpretation of at least 300 chest CT scan acquisitions in the past 3 years, and then documentation CME via the ACR, which again focuses in on the Lung-RADS, but then again I'll mention the MEVIS app that I told you that would be very helpful for radiologists. These are just some practical slides that I'll go through relatively quickly, but this is what the screening questionnaire looks like. So whether it be done in person or by phone, this is what your administrative staff or desk staff could be running through with the patient, so it's very self-explanatory, so the phone calls that are made. We noted here that we've included the group 2. This highlights again when you're ordering your scan, this is actually out of EPIC, and so when we complete an EPIC order for lung screening, we are including the key criteria and documenting, by signing this order, we certify that the patient is not symptomatic and they've had counseling. So this little box on the far right actually kind of highlights that information that meets the criteria by CMS. So to kind of bring this home, maintaining accurate patient follow-up is probably one of the most important things with starting screening, is to be able to finish what we start. And if without a database, a structured reporting system, and a navigator to navigate both the patient and a navigator to navigate the data and keep the database current, and surveillancing the data on at least a monthly basis. We cycle the data weekly and get reports out to the steering committee that comes through our navigator. That kind of helps you reassess your benchmarks and how you're doing, but also to make sure you're trying to have high compliance rate, reduction of loss to follow-ups, and patients leaving the program maybe prematurely. We don't want that to be a system reason that the patient couldn't get scheduled or or fell through the cracks. This is a way to prevent that. And also to be accountable to especially your Lung-RADS 4, so that those patients who are more likely, if any patient, to have an abnormal finding that's truly likely to be cancer, that those patients are not getting lost. And then I'm just trying to be mindful of the time here, but some practical things, and this is also in our toolkit, but we have a team who are just amazing. This team who is just diligent on a daily basis. Patients get a result letter. The physician gets a result letter. There's a 2-week phone call made to assure that the patient received the letter, and that if action needed to be taken due to incidental findings or an abnormal finding, there's communication made with guidance for the patient and also guidance for the primary care. And then, again, a phone call 2 days prior to their appointment, i.e. their CT scan procedure specifically or their next clinical visit. If the patient misses their exam, their scheduled exam, a reminder letter goes out at day 30. Another letter goes out to both the patient and the PCP at 60 days, saying the patient did not come for their scheduled appointment for their lung screening scan. And then a final letter at 90 days goes back out to both parties, encouraging them to re-engage, but not obligating them to that, but making sure that they're informed. And then we track, again, all the Lung-RADS 4s, chart review to see what happens to those patients. Do they get biopsied? Do they get followed? If they get biopsied, do they have benign disease? If they get biopsied, do they have malignant disease? This is just a kind of a standardized way. It's a tracking tracking. It's a database tracking system with all the demographics. radiographic characteristics, ultimately the findings, cancer or not cancer, and what the follow-up and care plan was thereafter. And I'll just kind of go through these somewhat quickly. And this is just an example of what the letter would look like, template for the letter for the patient. And this is also one of the resources for quit smoking, with ample resources both by phone and by online, and hard copy materials for patients to quit smoking. And just in the last couple of minutes, I'll just kind of, I want to leave some time for questions, is what have we learned so far since 2012? We actually were the first designated American College of Radiology lung cancer screening centers meeting all the criteria. The evolution, this is in our first year, just to kind of show you where do the referrals come from. And I would say, again, primary care still and is actually ever increasing. It becomes your #1 referral source. That's why there's so much importance in investing and having them be part of your program early on to get feedback and work collaboratively with them and you end up helping each other. We did a number of different ways of getting the word out. The first thing for us is that our institution committed to allowing us to offer the scans for free before CMS coverage. That was a very unique opportunity, and that's, I think, in large part why we've had such a successful program, screening almost 4,000 patients so far. This is just an example in relative from other centers who are doing lung screening, just kind of demonstrating the differences among programs and where people are in the process. And as I mentioned, we've actually identified 100 lung cancers as of July of this year from our program. This is an important piece, too. We talk about stage shifting. And if you recall in the NLST, there initially, with the initial round of screening, the majority of patients were actually advanced stage cancers being picked up. And then as screening progressed over those 2 other cycles, there was a stage shift where the majority then became early stage cancers being picked up with screening as opposed to late. And we've actually reproduced this same finding with actually even a higher incidence of earlier stage in our non-small cell population. And we embedded this slide. This on the right is the NLST data. And you can see those who got screened versus those who didn't. And our template on the left is showing the stage shift of now picking up earlier stage cancers. I think a lot of folks are kind of interested in what else did we find, and so the S, again, category S, for every 4.5 lung cancers detected, there's 1 extrathoracic malignancy picked up. Although these numbers are not huge, the total incidental findings that were significant over time, 28, and there's a wide spectrum, and it kind of goes without saying, because of what the CT scan encompasses, we're picking up a lot of other things, not to mention benign significant things, specifically coronary calcifications. And there's research ongoing here now identifying that there are patients with a certain finding on lung screening with coronary calcifications that puts them in the highest echelon for an event, an anticipated cardiac event. We're working with cardiology on that. Other things that you might find interesting is that from June to June 2014, just a benchmark, we had identified 1.5% of Lahey patients out of 1,654 patients screened were 4S positive that required surgical intervention. And of those, 20 of those patients were malignant. 5 cases were benign and with 1 complication. So that, again, using multidisciplinary tactics to review these cases before moving forward with an invasive or escalation of care, we're actually able to reduce the false positive escalation even compared to NLST. The other thing that shifted over the last 4 years is that the threshold for a positive Lung-RADS screen, the threshold changed. They shifted the nodule size to 8 millimeters, and therefore that markedly reduced also false positives. This is also the Group 2 information I mentioned, if you notice here in our database. So in parallel to our Group 1, we have found a similar pattern of incidence of lung cancer in the Group 2, meaning they are a younger patient population, have a lesser PACUR history, and they have quit smoking for a longer duration. But interestingly enough here, we've at least identified that they're a relatively smaller number of patients who fall into group 2, but the incidence of lung cancer is comparable. We've had a tremendously successful patient compliance rate, 85.7% compliance for lung screening. With those who were not compliant, some patients opted out of the program. They were not able to be reached with all the contact information we had. There was inability from request to their primary care to get an order, and some patients went elsewhere to other programs. I've already talked about the reminder process. Other things that were interesting, patient compliance with follow-up recommendations and reasons for non-compliance. The most compliant patients are women and patients who are in the retirement age. Other important opportunities for a young program is work out of our department by Dr. Jimenez, one of our prior fellows, and Dr. Tony Campagna here at Lahey. They said, well, maybe there's some unexpected opportunities here. And what they identified, they went to the PFT lab and basically identified of those patients, of 3,000 or so patients who had PFTs, 634 met criteria for lung screening. And this is, again, very early, and this is the first year of our screening program, so everything was new. Lung-RADS was new. Education for this was new. 564 patients were not screened, and when they really broke it down, based on just age and PAC year history, there were opportunities that we since have capitalized on, giving empowerment to our PFT lab to inquire about smoking history, which they do as part of their PFT questionnaire, but also offering them smoking cessation materials and FAQ sheets if the patient wants to inquire more about screening. But what was interesting here is that there were patients who, even though they met age and PFT criteria, when you drilled down on their other confounding variables, they did not meet eligibility criteria because they had already previously been diagnosed with lung cancer, or they were already being followed with other imaging previous to lung screening, and there were other variables, as I mentioned, for them not being screened. But we were able to capitalize and increase that number over time. And last but not least, these slides are really for your education, but just again, the power of smoking cessation opportunities, and CMS and USPTF has required this. These stars really highlight our Lahey program, and it goes back to saying that we identified 11 teachable moments to keep bringing the point home, not only to talk about smoking cessation, keeping the patient who's already smoke-free to remain that way. We had marked reduction in relapse of patients in the screening program because there were so many opportunities by different providers and different people reinforcing smoking cessation, providing tools. So I think that's a very important point. And these are the 5 A's offered by the USPTF task force about how we go about counseling, and having a very intentional strategy does make a difference, so specifically the 5 A's. And this is our outreach. These are all the different programs or institutions that have reached out to us, either with us coming with on-site visits, telephone conferences, or reaching out with program or toolkit materials, who have utilized some of our materials to begin their screening program. These are some of our publications that are for your reference from our screening program. And this is the link or references the Pulmonology risk model. And I'd like for you to see what you think about it. And then the Lahey toolkit has everything from soup to nuts of how to build a program and some practical tools that we would encourage you. It will ask you to register, but it costs nothing. It's just a way of us tracking who's utilizing our system and using our tools. And with that, I will stop, and hopefully we have a little time for questions.
So on behalf of myself and my co-moderator, David Shaw, I want to thank Dr. Lamb for an excellent talk. We'll open up the questions in a second, but I briefly wanted to announce our next webinar, which will be on Wednesday, August 17th at 7 p.m. Eastern Time with Dr. Adan Majid and Dr. Sadhu Gandharhan from Beth Israel Deaconess Medical Center, who will be discussing the management of tracheobronchomalacia. You can ask questions by typing them into the room notes at the bottom or clicking the raise hand feature and I will unmute you to answer those questions. For those who are audio only, at the end, I'll unmute the entire room so you can ask questions, but please mute your phone if you're not actively asking a question to avoid background noise. We have our first question, I believe, typed in. It is from, oh, no. So I actually have a question for you, Dr. Lamb. When somebody has a positive finding, category 2, 3, or 4, and needs follow-up imaging at a time period, whatever, based on it, are you typically doing the low-dose screening CT to follow up the positive finding, or are you using a standard CT for that?
That's a great question. So again, kind of reminding ourselves about Lung-RADS. So Lung-RADS 1 and 2, those are considered negative studies, and therefore just a repeat low-dose CT scan would be needed in 1 year. But if you're a Lung-RADS 3, that means there was you have at least a nodule that's below 8 millimeters. You may have either a ground glass opacity or some other configuration or something else in the lung parenchyma that is abnormal, and so that's considered a Lung-RADS 3. And that, if their recommendation based on the findings is that becomes the next step as a diagnostic. So you go now from a lung screening assessment to a diagnostic CT, which would be with contrast, if appropriate. And this is where clinical judgment is always going to take precedence. But if it's, and this is where the Lung-RADS icon or lexicon will say, consider clinical correlation always advised, right? And then it'll say repeat CT scan in 6 months. But if it becomes to follow or fine-tune what you've picked up on the incidental, on the screening, and that would be a contrast, now a diagnostic scan. So it would no longer be ordered as a lung screening scan at that point. It would be a diagnostic standard CT scan that would be billed like any other scan for a diagnostic indication.
Great, thank you. We have a question from Dr. Hsia as well.
Okay.
Dr. Hsia?
Oh, yeah, thank you. Thanks, Carla.
Sure.
So compliance is obviously a really important thing. Compliance in the NLST, one of the questions a lot of us have is, can we duplicate that? And I think it was on the order of 95-ish% or so. You have a compliance that's quite good as well, at 85%. So you mentioned letters, but aside from letters, are there any other measures that you are using to encourage compliance? And it's always hard to answer, but for some institutions that can't realistically achieve that kind of compliance, what are some of the downsides or to a screening program in that situation, or is it worth doing it? Where do we draw that threshold line?
Mm-hmm. Yeah, it's really important. So, we all know that because NLST was a true research model, and there were people, assigned probably one-to-one, almost like one-on-one. They were able to really capture those patients. There was a kind of that research diligence. So that's a high bar for anyone, to do that. But I think what we found helpful, there are several things. I have to give tremendous amount of credit to our radiology department. Brady McKee, he made personal phone calls or email contacts to the primary care physicians. And so I think, I guess what I would tell you, letters are important. Having a way of tracking letters and having phone call accountability, that that a call was made, an interaction happened, and what was the resolution of that Q&A, and then all these different loops of communication. So I think the first thing is to have that standardized navigator, whether, and it doesn't have to be a physician, but in our program, the radiologist really took on a lot of this, very much like they do when they think about IRADs for mammography. That's very radiology driven, if you think about it. That it took the dedication, I think, and the diligence of individuals. And so I think making that physician-to-physician phone call was very powerful, or making at least some sort of either EPIC communication by the electronic medical record or some sort of messaging, so that there was communication to the physician to physician to kind of keep that ball rolling. And then the navigators would go back and cycle back to see, if Miss Jones was scheduled, had her CT scan, and there were findings, what happened to Miss Jones? So now, in our own institution, if it's a Lahey patient, we can track that very easily. And so we had ability to kind of see what happened to that patient, and to some degree reach out to the care providers in some way to just circle back and make sure that something hadn't gotten lost in the course of things. But I think it's a challenge. I think it's probably the hardest part. So I think it's important for a program, before you really launch into your program, you have to have these key people hired and in place. It's a full-time job. It really is. I mean, to have someone to man the research, and then you have someone to, again, navigate the patients. You really need to lobby for FTEs from your institution for billets